So the objectives that I would like to go through today is just talking a bit about the background and statistics behind resuscitation, understanding why we have these discussions and what the importance of them are, being able to give you some tips onto how best to deliver this information to patients and also their relatives. Um, Also understanding properly what Dnacpr actually means, and what information is included on a treatment escalation plan form. And just as an added extra, to discuss a bit about why this is relevant in the context of COVID. So, for a bit of background, resuscitation is ultimately a medical team decision. So, a patient can refuse resuscitation, but they can't actually request it. Um, I mean, having said that, there is potentially, examples of legal cases in the past, where patients have, strongly requested it, and family members have strongly requested it, against sort of medical advice. And if the reasoning behind the medical team's decision hasn't been clear, or documented properly, then oftentimes the medical team can be penalised for that. Um, but usually the decision is discussed with patients and their relatives, um, and unless the only reason why you wouldn't discuss that with them is if it would cause the patient physical or psychological harm. All of these discussions should be very clearly documented. Like I said, there's a lot of legal implications to this. It doesn't mean to stop treatment altogether, um, but obviously just to have that sort of escalation plan. Um, Before COVID, usually this would need to be signed by a consultant, but during sort of the time of COVID, oftentimes um, registrars were sort of able to sign this, just because more of it was needed. Previously, a registrar could sign, but then would need a consultant review within sort of 24 hours. If a patient lacked capacity, it would be important to discuss this either with a lasting power of attorney, or if that person isn't available, any sort of close family or friends, just to get an idea of what the patient's best interests are. But if that's not available, then you need to involve an IMCA, so an independent mental um, capacity assessor. So, just some statistics for you. Some patients and their relatives like to kind of think in statistics, so it's sometimes nice to have a bit of an idea of what you're on about. So, these statistics are from the Resuscitation Council. They're from December 2015, so they're a bit old now, but they're relatively sort of relevant still. They did a study that essentially compared success in CPR and cardiac arrests, on weekdays, weekends, and then comparing day and night. So you'll notice obviously the worst is at nights, which has about a 39% success rate with 14% surviving to leave hospital. With a lot of these, you'll see that often they will have ROSC, so they'll have a successful cardiac arrest, but they won't often survive their stay in hospital, so they can sometimes die a few days later. Um, People tend to quote to relatives about a 10 to 20% survival rate, which is sort of goes along with these figures you see above. Um, and often, obviously, the success of these attempts will just decrease with multiple comorbidities. And if it's a non-shockable rhythm, which often is the case with patients who are very unwell and have multiple comorbidities, and it's not sort of, a cardiac in origin resuscitation. So the importance of having these discussions, it's obviously important to try and have these decisions early, ideally as patients come into hospitals. The main thing really is just to sort of help avoid bad deaths. So I think that's something that is important for both. It's important for patients, it's important for family, and also important for the staff that are involved, because often it can be quite traumatic. If family members are there, or even just for all the staff members involved in it, if someone's unnecessarily receiving CPR when actually it might have been a lot more peaceful for them to just sort of pass away, without that kind of hullabaloo, I guess, going on around beforehand. Um, Also, for you guys, it is a very good example of a communication station, which has often been used in OSCEs in the past. So that's something to sort of just keep in mind and, practice doing this amongst yourselves. So the best way to approach having this discussion, I think, obviously not to just dive straight in. It's sort of similar to Breaking Bad News. It sort of works best after you've built up a bit of a rapport, discuss any current problems and ongoing management, and sort of update them on that. Usually best to include in a wider discussion about any treatment escalation or advanced care plan. Um, so, if you're speaking to the relatives, it's important to ask if the patient's ever expressed any wishes or any previous discussions. Um, so, asking if there's anything that, uh, they've ever expressed any particular wishes in that area. Also, just bringing up the term resuscitation and checking that they understand what that means, and then obviously explaining, if they don't know what that means, explaining what the term resuscitation actually means. So, saying this means this is actually just referring to jumping on the chest if the heart were to stop. You can go into why CPR would be unsuccessful. So, for example, listing the comorbidities that that patient specifically has, to put it into context better for the family members or for the patient. As with anything, we always discuss benefit versus risk with any treatment. And I think that this is no different. This is still a treatment, and we have to consider the benefit versus the risk. And actually, whether the risks could be that yes, it could work, but actually would the level of recovery be acceptable to the patient? Because some people obviously just would rather pass away and not be left sort of disabled in any way. It's really important to stress that it doesn't mean the treatment will stop. So, you'll continue with antibiotics, you'll continue with fluids, you're not going to completely cut off all treatments. As juniors, I think I was told, at medical school, you won't have to have this discussion. It's not something that happens till you're senior. But I think that actually, especially with COVID, we've been put in a position where we've actually had to have a lot of these discussions. And maybe it is, sometimes we aren't qualified to have certain elements of this discussion. So I think that if a patient or a relative really strongly disagrees, it's not your place to kind of force it. It's important as a junior to provide with all that information and give it to them in a sensitive manner. But if they're strongly disagreeing, then just escalate that discussion to seniors if needed. There's loads of, I'll provide some links at the end of this, but basically there's loads of really useful phrases that I've sort of picked up on from people or found, online. And so you kind of just design what's best for you. But this is just some of the useful phrases that I've found and people have given me before. So yeah, feel free to. So, like I said, basically anything, if there's no benefit, we're just causing harm. I think people are always like, is there nothing more that can be done? One of the palliative consultants once said to me something like, there's always more that can be done, and if there isn't, then we can at least give you sort of a dignified and peaceful death. And yeah, also this emphasis of even if they survive resuscitation, they're left with a poor quality of life. Would that be acceptable to you, etc., etc.? So treatment escalation plans tend to go hand in hand with Dnacpr. They determine what level of escalation and treatment a patient should receive should they become unwell. I think in most of the NHS, they're trying to roll out these respect forms, which are actually a sort of more personalised version of these sort of TEP forms or Dnacpr forms, which give sort of personalised recommendations for a person's clinical care in future emergencies in which they're unable to make or express choices. So what that really means is they'll have this booklet where hopefully they should bring it with them all the time, and it will just make clear what they want to get out of everything, and what should X circumstance arrive, this is what they want. So stuff like it will be quite specific within respect forms, which is quite one of the reasons it's quite good. But that's something, you can look on the internet and find that anywhere. And also when you're on placement, maybe just ask, because every sort of TEP form and respect form is a bit different in each hospital, but just so you get an example of what's sort of in there, ask whenever you're on placement to have a look. Um, but at Sandwell and City, the TEP forms essentially usually just involve questions like, would this patient be suitable for ITU? Would they be suitable for IV fluids? Would they be suitable for parenteral feeding? Um, things like that, and what level of escalation should they have? Are they suitable for NIV? All that sort of thing. So most of them generally sort of contain the similar thing. But yeah, it's worthwhile having a look and seeing what they're like when you're next on placement. Just a fun added extra, I guess. I thought I'd talk about COVID. I don't know how relevant it will be for you, but I think it is worth learning about now that it's a thing. Um, so just the nature of this pandemic just meant that we had to sort of push this more sort of advanced care planning. And it became more urgent, I guess, the advanced care planning with patients, because they came in and deteriorated quite quickly. So actually on admission, it was really important to triage patients into these groups for who was sort of a candidate for ITU, who was a candidate for NIV, and who was not a candidate for either of those, and therefore were sort of for palliation, DNA, CPR, all that sort of stuff. Um, Also with COVID, a lot of DNA CPR discussions are now having to happen over the phone with relatives who are unable to visit patients in the hospital. So it just adds a different element of communication. Um, it's a lot easier, obviously, to communicate with people in person, being able to sort of, uh, read their body language and all that sort of thing. But yeah, I think it's definitely more useful having the discussion rather in person. This link that I've provided here, this document, essentially is just showing, it's just some examples of sort of tips on having conversations, mostly surrounding COVID, and especially having them over the phone with patients and relatives. I think I can send you these slides so you've got the link. Okay, so I'm not sure if that works. I think you might have to get the link yourself, but this is just an example of like a good example of sort of what I've talked about already, some of the sort of delivering bad news and DNA CPR. So just to summarize, like I've touched on already, it's obviously important to discuss these things with patients and relatives early on. Often you can use these statistics, which can sort of help to explain why it's better not to attempt resuscitation. You can use certain phrases and techniques of communicating well. And like I sort of touched on, I think despite what you're told at medical school, there is a chance you will have to have these discussions. I'm not saying obviously that there's going to be another pandemic, but you never know. So I think it's good to be prepared and have at least some phrases that will help you to have these sort of discussions. There's just some references. Thank you very much.